It's all plants. I don't know if I'm doing any seed this year. I bought a whole bunch of seeds, but fortunately a lot of Dollar Tree. 4 packs for $1, I think. Not very many seeds in them, but all right.
I saw yellow corn tomatoes.
Okay. And that was 114 to 105 north. First road, turn right. First road, turn right.
Yeah, I was so excited too because we don't have cable either. We do Bible, and so we don't have live support.
We have a very big crowd here.
Sorry about that.
I like learning new things all the time. This is them.
It's time. I think it's time for us to start. I'm going to start this meeting tonight like we do church on Sunday. Welcome to all of you, and we welcome all the people who are watching remotely through the wonders of technology too. So I think we're in for an informative and interesting program tonight. This is Kimberli Pike. Kimberli is the director of the Nutrition and Nutrigenomics program at Manchester University in Fort Wayne. She is a registered dietitian. She's also board certified in sports dietetics. Kim's had a lot of variety of experiences in her work. She's provided care in clinical settings and sports settings and public health settings, including in oncology at the Ohio State University Comprehensive Cancer Center. She's taught college and university students in nurses training, athletic training, exercise science, dietetics, and a highlight of her career was serving as a consulting sports dietitian for the National Hockey League. She's also working on a doctorate with Rutgers.
I'm actually done, finally. Yes.
Congratulations, that's wonderful.
Thank you.
What a relief. In her free time, and I'm guessing she doesn't have much free time, she likes to spend with her family and dogs at the lake, or hiking, or traveling, or watching ice hockey.
It's a good time right now.
Okay, well, welcome, Kimberli.
Thank you very much. I'm very happy to be here, first of all, and I hope that the information I provide you today is something that's really useful and just kind of gives you a new perspective potentially on the field of dietetics, which is nutrition, and also nutrition itself. As Joanne was saying, my name is Kimberli Pike, and I am a doctorate of clinical nutrition. I was asked to give my credentials there, but I want to be very clear that I just graduated in January of 2023. It was something that I went to pursue as my daughters were finishing college. One was finishing college, one was getting ready to finish high school, and I thought it was time. This is my 20th year teaching, and I just felt like that was one of the things that I needed to finish. And so that's something that is, it was a lot of time and a lot of undertaking. However, now I have free time and I hear people gardening and all these things. I'm getting some ideas tonight, so with what to do with that free time. Tonight I'll be talking about something that's really very challenging even in my field. I've been a registered dietitian for 25 years. And in that time, 20 of those years has been in academia, also working in consulting. However, we have a brand new area and an evolution that's happening in our field. And as you're listening to different newscasts, and they're talking about things such as AI, artificial intelligence, such as informatics, such as kind of the Jetsons medicine. When we watched the Jetsons cartoons years ago, the things that are actually happening, they're actually coming true. And this is one of those things that I would put in this category, but it's a little more meaningful to me having seen the evolution of our field. And so I hope to share some examples with you tonight. The first thing I would like to share with you, though, is what is a registered dietitian. You see RD or RDN, registered dietitian nutritionist. Now, I put this question here because I have been an RD, like I mentioned, for 25 years, but I still have to explain to my parents what I do. So I thought it'd be helpful to just explain that a registered dietitian is an expert in human nutrition and metabolism. And we look at the mechanism of food as a chemical. And so when we look at food, for example, we look at a fruit or a vegetable, for example, we break it down to the chemical components and think about how that's going to interact within the body. And some people have some variances from other people. Not everyone will respond the exact same way to the same nutrients. Not everybody will have the same benefit, for example. Some foods can be not such a great benefit, more of a harmful type of addition for some individuals, especially those with predispositions to medical conditions like cancer. And so we look at that and map out the metabolism. I like to compare it, since I'm in a school of pharmacy now at Manchester, I like to compare that to pharmacy, who looks at the drug as the chemical being applied into the body and its mechanisms throughout the body. We're looking at food as a chemical, so it's just a different version of the same thing, but looking at the metabolism and how our body uses that. In our profession, a registered dietitian will alter a patient or client's nutrition prescription. That is something that we do. We do something that's a full process of assessment, nutrition diagnoses, and then we intervene. We try to decide what is the best fit for this individual, and I'll explain that as we go today. We also look at how to monitor it, how to make sure that what we're saying to them actually gets incorporated and potentially improves their outcomes. And so that process is something we will follow with all different types of patients or clients, people from all different ages, from even preconception through the full life cycle, and also people with all types of nutrient needs that are related back to medications they take or conditions or diseases. Now we're taking it even a step further to look even further at what their genetics look like. This is the science of nutrigenomics, because not everyone does the same thing with the same chemical in the exact same way. For some, we may have some really positive outcomes, some we may not. I will also say, too, as far as the medical team is concerned, registered dietitians are the individuals that are looking specifically at nutrition and nutrition pathways. And with that, we are licensed, and we are part of the team that helps decide how to feed the person, regardless of their obstacle. We look at several different things that I'll explain on the next slide, that we look at how to deliver nutrients to be able to sustain a person. And so we look at nutrition delivery and provide what's called medical nutrition therapy. Our scope of practice, then, if you're looking at the medical team again, every person on that medical team comes in and looks at the same person, but they have a completely different perspective. We all are looking with different eyes and different training. And for a registered dietitian, what we are looking at is the ingestion or the path to get food into the body. That's the first thing. Can the person swallow? Can they chew? Do they need a feeding tube? Are they conscious? Do they eat? We look at how the ingestion happens, or getting food into the body. We can even back that up a few steps of how they even acquire food, because we look at our world, we don't have equal distribution of food, and some people are food insecure. They're not able to get the food that they need on a regular basis. And so that's encompassed more in the community-based nutrition. Once food is in the body, we look at digestion. Do they have the adequate stomach acid to be able to get vitamin B12 uncoupled, for example, from proteins? Can they actually break down the nutrients efficiently? We have a lot of people that have malabsorptive issues, for example, because of that. And so we look at the mechanisms in the gastrointestinal tract to make sure that a person can make optimal use of food coming in, and making sure that they're able to digest and utilize those nutrients. We look at absorption, how food travels from the digestive tract into the blood or into the lymphatic system, depending on the type of nutrient we're talking about, and how it arrives in the cells, where we actually convert that to energy or convert it to new products, like new muscle, for example, or building new blood cells. And so we look at that full metabolism and that full avenue. Probably the least exciting thing on this list is excretion. We also look at excretion because we look at making sure the person does not have hyperactivity in their GI tract where they have persistent diarrhea, for example, something we see a lot with people with radiation therapy, for example, and cancer, or potentially GI diseases or conditions. On the flip side, we want to make sure the person can regularly excrete food and not have obstructions or any kind of other issue. And so we follow that chemical. We follow it even in the farms to see how things are grown and everything else. Follow it to how it arrives for the individual, how they ingest it, and how it works through the body. And so when we look at scope of practice, dietitians really are looking at that whole mechanism and deciding what might be best for the person in front of them. There are some other things that we have to take into consideration because we do also know, I have this in red because it's obviously what we're going to talk about a little bit more today, but we have that interaction between genetics and food, and also food and metabolism, how they interplay with the person's genes. This is a new science. Just as recent as the early 2000s, we did the Human Genome Project. In that project, we isolated over 80,000 different variations in a person's genes. And those variations only account for less than 1% of our total DNA makeup. And so just that slight shift, that slight change, person to person, can tell us a lot about what happens when they eat carbohydrates, what happens when they have problems with folic acid, a B vitamin. All of these things are being uncovered just in the last 24 years. It's really amazing. I'm very young in science because when we consider things like most science, it's hundreds and hundreds of years old. We've known things for several years, but this is evolving very fast, and it's just with its roots just in this millennia. So we're seeing very early evidence and research and things coming out telling us more and more every day about what happens with individual variants. We also have to look at medications because foods and drugs interact a lot. Sometimes you can eat a certain food and it'll enhance a medicine in a way that we really don't want. Maybe it makes it a little too powerful. Maybe it nullifies the effect of the drug. Or we may see the drug may interfere also with the absorption of a nutrient, causing a secondary deficiency or other problem. And so we look at these things very specifically when we do when we look at our scope of practice. We also look at adaptations to metabolic needs. This is one thing that I think all of us as Americans, we get a little bit blindsided by this. If a person has the recommendation of My Plate, for example, what used to be the Food Guide Pyramid, before that we had the 4 squares, all of these different models that we have of proper nutrition are made for adults. They're made for people without any diseases or conditions. And so every time I think of that, it shrinks that pool of people that they're really specific for. It's a great guidance. It's a great place to start. However, anytime a person has a disease or condition, that disease or condition is a change in their metabolism, and that automatically affects some nutrient in some way. So the way that they're able to bring foods in, the way they're able to utilize them, all changes with diagnoses, or even conditions like if they've had a car accident, a fever, infection, all of those things change our metabolic needs. And so this is something that the dietitian is looking at. It's more than eat this, not that. There's a lot of assessing that goes on and a lot of things that we're looking at. But we're also communicating that back to the physician. We're communicating it to the nurse. We're communicating it to the pharmacist who might be working with a medication, and maybe the medication isn't working optimally. Maybe it's something to do with the food or the diet. And so we have several things that interplay there. So with this, we have several different things within our scope. And again, a lot of it is the dynamics of the food as it goes through the body. We also have several areas of practice, and this is something that I really get excited about as an educator in dietetics. I was an undergraduate program director for 18 years prior to coming to Manchester to work in the graduate program, and I was really kind of blown away because when I went through school, we had 3 primary areas of practice. They were community, they were clinical, or you could work in food systems. And from that point, we have had an explosion in our field where we have over 40 identified areas of practice. And so we have a lot of specialties. These are just examples of those. I still have the primary domains of clinical, community, and foods. But we have several very specific areas of practice and specialty. We also have some nice emerging pathways, which are kind of new. They've kind of evolved into our scope. Things like sustainability, making sure that there's enough food to go around. Also making sure that we are looking at chronic disease prevention. We sadly have been on this model of healthcare in the United States where we're just reactive, we're not proactive. And so we're looking at healthy aging, we're looking at chronic disease prevention, and we're also learning more about interprofessional work, where we start to collaborate more, rather than just going to the chart, looking at what I need to look at as a dietitian, charting my notes and not speaking to anyone else on the medical team. We're actually looking at holistically at the whole person. And so the evolution of medicine is really great. I know I skipped one, and that also is for a reason, because another area is personalized nutrition. You might also hear the term precision nutrition. And essentially, this is a brand new emerging area of practice called nutrigenomics. What this means, nutrigenomics, you can kind of break down, it's how your genes interplay with the foods that come into the body, and how some people may have very different reactions to the same food, same diet, same conditions, same exercise, everything, but just respond very differently. And so with that, I wanted to just point out the National Institute of Health has a $170 million budget for nutrigenomics. It's that wide open and that needed. They have a lot of research initiatives going on through 2027. And with that, we're hoping to even build on the body that we have, that body of evidence that's getting bigger and bigger each day. Now, I'm very excited about this with nutrigenomics. As I mentioned, it's a new science. It's only about 20 years old when we talk about the grassroots of nutrigenomics. If I were really talking about how long we've had nutrition-specific genomics research, it's only about 10 years. It's very, very new. And with this, some of our findings have been kind of accidental findings. Research, when we're looking at other genomics research in biology, we happen to realize that there's just something different about this group with this genetic type. And they started looking at it and do prospective studies looking forward and realize it's a nutrition effect. And so this is relatively new, within about 10 years. And in that time frame, we had a sister sidestep with pharmacogenomics, which looks at pharmacy and the way our body interacts with different medications. I'll explain that a little more too. But Manchester University was one of the first in the nation to have a pharmacogenomics program. And so when this field started evolving, they started thinking right away, this is the way that our medical profession is going. This is the way dietetics is moving. And so they were very proactive and worked very hard at putting together an accredited program pathway to help train registered dietitians in a traditional way. We still have a traditional pathway. However, it's enhanced with courses specific to learning more about genetics and marrying biology and pharmacogenomics with nutrition. And so it's a very proactive program. And so this is where I'm very excited about it, because it is one of the only two that I'm aware of in the United States. We have a program, University of Connecticut had an accredited program already in existence, a traditional program, and they've added a nutrigenomics track. Otherwise, other schools, including Rutgers, where I just graduated from, they just had a course. That was the limit. They have a course to teach about nutrigenomics. And so this is something that is really groundbreaking right here at Manchester University. And so it was one of the reasons that really excited me about this position as well. So with this program, again, this is a 20-month program. I have a brief overview of it, but we have a traditional pathway where people learn the competencies for our field and prepares them for a registration examination that they take at the end of the program. But it is a novel inclusion of genetics with nutrigenomics, and they have a genetics lab that's available on campus as a rotation for students to come in and even run their own DNA through a lab to be able to see the report on the other side and simulate what they would say to a patient with that same DNA. So very exciting stuff that's happening here through Manchester University. We also see, too, that it ties in very nicely to that the Manchester mission. That mission focuses on improving the human condition, and this is done through, in our case, it's done through more personalized nutrition. Now I'm going to get in, it sounds like personalized nutrition, it just sounds like someone's just writing you up a diet plan, but I'll get to the next couple of slides where this really speaks to why it's so important. This is just a very quick overview. I promise not to go over the whole thing. I do this so many times with students from undergraduate programs at Taylor and other places where I've gone to speak to talk about our program. But very quickly, it is a 20-month program. We do have genomics as an option for the rotations, but otherwise they do the traditional pathway of training, which all registered dietitians do. with at least 1,000 hours of experiential learning in a hospital setting or in other related settings like community nutrition. But they are coming out of our program not only registration eligible to take the national registration examination, but they're also able to perform at an enhanced level. And that's where I wanted to show you what enhanced level looks like. In dietetics, one of the first steps that we take, anytime we are speaking to a patient, anytime we're looking through a medical chart, if we are able to speak to the patient, of course, that would be one of the things in an interview with an outpatient, for example. But we are looking at nutrition assessment. And nutrition assessment traditionally has these 6 categories. The 6 categories are that we do look back at what they're taking in as far as their food nutrient habits. If it's a person who's on a tube feed, unconscious in the ICU unit, we would be looking at their charts of what's been delivered via IV or via tube feeding. But we look through and we try to look specifically for gaps or things that would be of interest, maybe deficiency areas or areas where they're over or under consuming or becoming malnourished. We also look at anthropometric measurements, the person's height, weight, all of those things that we love to get done at the doctor's office. But what we're looking at too is changes over time. So for children, we will be looking at growth charts. We're looking to make sure that we are growing appropriately at the right velocity of growth and not stalling out. We do see that with failure to thrive children. And in adults, we want to make sure that we're not losing muscle too fast. Muscle is very precious. It makes one of the biggest markers of our longevity, of our health. It was reflective even of our immune system and the strength of our immune system. And so we start to see these things tie in. And so we do this as part of our assessment to try to get an idea of the person's nutrition status. Now, I'm going to skip over biochemical for just a second and go to nutrition-focused physical examination. The nutrition-focused physical examination is a physical examination that hasn't always been part of our assessment, but now we have enough evidence to show that we can detect problems or changes long before a blood lab, long before we see a person really show a big change in weight, or their body weight reflects that they've lost a lot of muscle. If we physically look at them, we may see that they have some loss of muscle in key places that we would do through this examination. We also look at the skin integrity, making sure that we have no skin breakdown. That can't be measured in a lab or any kind of lab draw. And also we start to look at orofacial effects. A lot of adults are very good at, they just adjust when they have problems with swallowing, when foods get a little bit difficult for them. Maybe they've had some repeated choking accident or incidents, or they've had allergies or some type of allergic reaction. We're very good at adapting and not really recognizing that this is a nutrition problem. I'm having problems coordinating my swallow. I'm having problems creating enough saliva to be able to swallow easily. These are things that we look for in what's called an orofacial examination. And it tells us a lot about what the person is capable of doing, maybe moving food from side to side in their mouth, coordinating their swallow, things that are all a very critical piece of the puzzle for us to look to see what's critical for nutrition. We also use assessment monitoring and evaluation tools. These are tools that are validated for use, meaning that they've had a lot of research behind them to make sure that they measure what we hope and measure what we're looking for. The biggest one probably is that we use malnutrition screening tools. If any of you have gone to a doctor's office and they're asking you questions, maybe 5 quick questions about nutrition, you're actually doing a malnutrition screening. That's pretty standard in most physicians' offices, and also as a person might come in through ER or into the hospital, they would always ask specific questions that are doing these screenings behind the scenes. And those results then go to nutrition services. Now, I left out biochemical data because biochemical data is something we use a lot in nutrition and dietetics. And what this is when you have a lab drawn, say you have a cholesterol panel, well, we definitely are looking at that. We're definitely looking at blood glucose and what you're doing with blood glucose. But some of the other tests that are available aren't routine, but they tell us a lot about how a person is going to respond to specific changes in their diet. And this would be with genetic testing. Now on my slide, I mentioned nutrition assessment. By itself, we would do all 6 of these categories. We would look at your labs and see if your iron's low or if you're having problems with your inflammatory counts like CRP and things like that being high. But what we don't have all the time is that genetic testing. That genetic testing is actually what makes this an enhanced nutrition assessment. If we have that information, we can interpret it in several different ways, several different diseases and conditions, and also different foods, food groups, and non-nutrients such as components in plant foods, for example. The things that give plants their colors also are very bioactive. And so it tells us this just from looking at these genetic results. Now, again, the big key to enhance nutrition assessment, the biggest thing that we see are things that we have in the past, we have had no way of determining or no way of uncovering. We can't do a physical test to look and see if a person's genetics might be an influence on them. We can't really tell that. I have a picture of my sweet little dogs here. Does anyone want to guess what their tie together is? They're litter mates. They were born from the same mother. You would never know it by looking at them. One looks like a black lab, one looks like a Great Pyrenees. You got father and mother right there pretty much. But genetically, I could look at them, I could examine them all day long. I could look at their labs outside of that genetic testing and never know that they had a common thread. This genetic testing is actually pulling those common threads together and helping answer questions that we've had in research and nutrition for decades. And so this is exciting for us. This is something that we can use to really have a great tool in our toolbox to provide better care for our patients and clients. So when we have this information, this leads to that enhanced nutrition assessment. When we have the information, we can get a better nutrition diagnosis and really understand why this person isn't responding the way we think they should when we do a diabetes intervention. Why are they not responding when they're on this medicine and they're eating these foods? Why are we not seeing these cholesterol labs move? Why are they salt sensitive? Or I've tried to take all the salt out of their diet. Is their blood pressure not going down? Because other science has told us that should happen. Well, what we're finding is that there are genetic changes in that adaptation, that less than 1% difference person to person, that make a big enough difference to impact the person's overall health. And so that's really where this becomes so critical. So when we can get a better nutrition diagnosis, we do a more enhanced and expanded type of assessment, we can really get a better idea of what truly is the root of this nutrition problem and convey that to the rest of the medical team. So this is what we think this issue may be. From there, we can get better plans together and use the evidence, use the new research, the information that we have coming toward us that tells us that this person is going to respond a little better if we just supplement them with more B vitamins, for example. Now, it's not that simple, but there is one that is pretty simple like that I'll explain. But we may be able to improve their protein intakes and help them prevent really quick loss of muscle. Those types of things, again, give us better plans that are more precise and definitely much more individualized. And so this is where this enhanced focus in our degree at Manchester really does benefit. It's going to really help improve the outcomes for patients and clients of our graduates. And so this area is very important. It's it's again, evolving all the time. But then it also gives us more effective monitoring and evaluation plans. So that way we can really measure to see, okay, this was the DNA result that we saw for this particular gene. We adapted the diet, explained it to the patient, adapted the diet, and this is the outcome to make sure that there's a difference from before. And so we capture all that information to make sure that we have better interventions overall. Now, I know it's kind of in the clouds a little bit of how this actually works, so I thought I would give you a few different examples of things that have been very well established in scientific literature. When I say this, most of the first research in any of these was around 2006, 2007. That's the first grassroots research in any of these areas. From there, we have several others, but these are very well established. And one is the CYP gene. It's CYP1A2, and this is actually a gene that determines if you are a fast caffeine user or slow utilizer of caffeine. And not everybody consumes caffeine, but most of us do. By show of hands, do most people have coffee in the morning, for example, or tea? Caffeine actually is more in the pharmacogenetic side because it is more of a pharmaceutical. It is definitely a stimulant for some people. However, when we look at it in the nutrition side of things, we see a lot of sneaky caffeines coming in through things like teas or different plant-based foods. But we start to see a difference with the way a person metabolizes caffeine that some people can have that 1 or 2 cups of coffee in the morning and metabolize it just fine and have no issue. However, others, it stays in the body a lot longer. And I'm going to use the example of a person who has hypertension. We're trying to slow their blood pressure down with their medication, and that slow metabolizer of caffeine actually won't get that effect as well from the medication. The caffeine actually keeps them stimulated and keeps their heart pumping twice as hard, or not twice, it's not scientific, faster, let's just say that, harder. It keeps the heart working at an amped up rate for longer, and the medication is not as effective. Now, this again, I mentioned just from 2 cups of coffee per day. For people that we think might be a slow metabolizer, we'd like to limit the intake under 200 milligrams per day, which is about a cup a day of coffee. But what we see now, though, from this early research is that a cumulative caffeine use for people who are slow metabolizers may actually impact a person's risk of diabetes. It might actually impact a person's risk of kidney disease. All of these things are consistent with the way that they metabolize caffeine. Now, is it just caffeine? We don't know. This is what we've isolated so far. Maybe there's other factors, whether they use cream in that coffee or not, or other factors with that. But for the most part, we're starting to see that these slow metabolizers definitely are higher risk people for certain conditions. This also explains to us, too, why we have some research that comes back, and you have all this body of research that says, well, if you just cut this back, then we'll see a benefit for this part of your health, this type of condition. And then we always find the rule breaker, the person that shows the opposite. And then our research gets caught up, like on one side of one camp says it's helpful, one camp says it's not. It gets really confusing to the consumer. We think the reason for a lot of this is most likely related back to things like this with the metabolism of different nutrients and the speed at which you metabolize. Now, there's another one that's very important. It's not on this list. It's new. And when I say new, this is the first large studies of over 170 people in the studies that I'll explain later. Some of the new information is also showing the same for dietary sodium. I'm sure if you have hypertension, you probably have had a physician or dietitian tell you, it's time to cut back the sodium to help your blood pressure out. Well, what we're finding is that there's a large population of people with a variant in that gene that doesn't result in any changes at all for blood pressure. However, there's a small fragment of people that have a different genotype that are affected by the salt content of diet. And it's big enough to impact the outcomes of studies, that people in these studies for a long period of time, they're very, very sensitive to salt. And so they will throw or skew the results over that it would look like everybody is going to be salt sensitive. So if you have a friend or your relative or even yourself who has been on a salt-restricted diet forever and it's had no impact at all on their blood pressure, maybe they're not that genotype. Maybe we're looking at a difference in that gene. We also see, too, I have some other examples of ApoE, which is fat metabolism. And this is something that affects a person's fat metabolism and transport through the body. So they tend to have very high cholesterol and very high triglycerides. And even if we do a diet intervention, a lot of times we don't see huge results for them. Now we try to change the type of fat a little bit. We've tried different things with this. And what we found is actually it's the type of fat, not just fat itself. We don't just go on low-fat diets, but certain types of fat that increase inflammation a lot in those groups, those people with that gene. And so when that increases, they start getting really inflammatory and start to have really high CRP levels and sedimentation rates, other types of inflammatory markers, and their body is just not metabolizing that certain type of fat the same. Now, those fats are also often the types of fats used in processed foods. And so when we've looked at diet research for years and thought, oh, it's the processed food, it has to be the process that we're using, whatever we're doing to make that quick, convenient food, it actually is probably the fat that they were using and the type of fat that's very cheap and very abundant that actually is lending to this response in this segment of the population, these people with this certain genetic shift. And so what we find now with new evolution of this study and these types of studies, we are seeing it associated with other inflammatory type diseases like non-alcoholic fatty liver disease. This is like a lot of us may have heard of cirrhosis in the past that people get from alcoholism. People are getting cirrhosis-like effects just with obesity and just different diets now, not necessarily because of alcoholism. We also see Alzheimer's disease in that same category. because the inflammation is what changes the brain chemistry. And so we start to see that systematically. We start to see some problems, cardiovascular and coronary heart conditions, but also Alzheimer's disease as well. Much more common with that ApoE gene that's showing up in their DNA sequence. We also have the COMT, which is a modified for cancer preventative role. And this is because they tend to utilize vitamin E a little differently. They're not quite as efficient with vitamin E. And so they tend to have an increased risk of colorectal cancer whenever they have this dysregulated gene elevated. And our reports that we would get from a lab would tell us that this is elevated. So we would need to make sure this person has much more vitamin E in their diet to counteract the effects of not being able to use it at the best level or most efficiently. So we can usually increase it to help lower the person's risk of colorectal cancer. Now, this last one is actually one of the first things that we found. And I would guess that someone in this room has Irish ancestry. Irish ancestry is usually where this happens. And most of our most exciting research actually came out of Ireland with this, even in the small, pretty homogeneous populations of Ireland. It's called the MTHFR gene. And this gene actually impairs our use of folate, which is a B vitamin. And folate is one, you might hear of folate, especially if you have anyone in your family who's been pregnant within the last, 25 years, because it's been a big deal in pregnancy care to help prevent things like neural tube defects and other types of birth defects. We also may hear about it in people that have heart disease, because people that have heart disease tend to have a high level of something called homocysteine. It's a byproduct of protein metabolism. And what we find is actually they have a defect of using the nutrient that should help them prevent the deficiency of folate and also help them take homocysteine into something that's not harmful to them. And they're lacking that because they have this gene variant. So what we find through these studies is they have typically very high risk of cardiovascular events like heart attacks, strokes. They have a very high risk of high blood pressure. And even if they consume folic acid through food, folate through food, folic acid, the pharmaceutical type of it, rather than what's in the food itself, is actually much more effective. And so supplementing them and making sure that they have supplementation to make up for this lack in their genes may actually help them prevent things like cardiovascular events. And so there's a lot of really great research like this. Now, as I mentioned with this, though, we have new things coming out all the time. And so I would almost venture say that you could look at pretty much any disease or condition and find some tie to nutrigenomics at this point. Again, one of the things that I was very interested in working with cancer and with cancer patients. And one of the big things in the Ohio State lab that I worked with that was my doctoral residency. Rutgers actually got along with Ohio State for a few days for me to do that. But I was able to work at Ohio State's CARE lab, and they work primarily with lung cancer patients. And they are looking at this information as well. And one of the things that they were able to find is very specific interactions with a certain genotype and also the person's risk or their severity of lung cancer. So it is beyond, of course, we did look at, smoking and non-smoking, and they even took samples of their gut microbiome, the bacteria that grow in your gut, did look for any differences as well. And so it's really very interesting to me that they just have this whole new world. And it's like we almost feel, you get to the point where you almost feel like, have we known anything up until this point? We're starting to learn these things that really tell us a lot about what's been going on with our patients. Now, I mentioned before, too, that this is kind of a sister program. Our program is a sister program to pharmacogenomics at Manchester. And I very briefly wanted to say they were one of the very first pharmacogenomics programs in the United States, if not the first. And this is also a similar type of science that's going on, looking at the Human Genome Project and the differences in genetics and how people respond to medications. Now, one of the things that I thought was so fascinating when I was working in the lab at the Ohio State University, when we were looking at pharmacogenomics, there is a very big variation on how a person responds to immunotherapy. It's a new class of drugs. And some people just respond beautifully, and we can keep them in kind of not really completely cancer-free, but at least cancer stagnated, where the cancer isn't growing as fast, and they can live productive lives. And maybe it's not curative, but it's still helping them live much longer and much better quality of life. This actually comes down to pharmacogenomics as well. They're able to really look at the DNA of the cancer cells themselves, and they have artificial intelligence that's been used to be able to predict what a person's outcome will be if they have this type of cancer versus another. There are over 200 types of cancer, and that each cancer type has a different DNA. And so that and the patient have different DNA. And they're able to use these different models to be able to predict what a person's outcome will be. What this does, if you're a person that has a loved one who's had cancer, I know I have had a family member I love very much with cancer, that person actually, this person, my uncle passed away several years ago. However, the difference is from then to now is had they been able to look at his DNA and how he would respond, and not only that, but the cancer's DNA and how that responds to certain treatments, he wouldn't have had to go through certain levels, like going through radiation and then chemo or both. And then they just throw everything at the wall and they start medications. And they just keep trying and trying. It's all from a good place. They're trying to help, but they don't have to try and fail so many things now to be able to find what works. And so that's really where pharmacogenomics is just brilliant. It's amazing science they're doing, but we're hoping to see the same impact so that people can get the best quality and best quantity of their lives without having to go through all of the wrong turns. And so, yes, the answer would be that it is very related to pharmacogenomics as well. I also, too, wanted to point out, does it improve outcomes for people to know their genetic factors or their risks? That's something that is kind of very difficult to decide. I have a nice cartoon for it, actually. You probably have two camps of people that take information and go with it, or they take information and they lay down with it. So a lot of it is probably like beauty's in the eye of the beholder. The reaction's going to be in the life of the reactee. But what we have found through research is that most of the randomized control trials that we have, where people were presented with their genetic information and given guidelines in nutrition, most of them were much more compliant. I hate to use the word compliance. It sounds really rough and aggressive, but they were much more in line, and they were on board with making the changes they needed to make to have better outcomes. And we also see, too, with that, there are several different examples of this, but one of our newest trials that came out is that we actually see some of the patients get some relief from this because it explains, maybe I'm not crazy. I did try everything. I did everything I was told, and I still got the bad outcome. So it actually explains some of those areas as well. And I think probably none of the areas would be as true to that as weight loss because it's so highly personal. It's so highly something people are very sensitive about. But when they did a NOW trial, the NOW trial is looking at individuals who were put in there was a randomized control trial. They were put in different groups. And with these two groups, one group got genetic testing and genetic counseling plus the diet intervention, and the other group just got the diet intervention. So they followed the exact same diet intervention, but what they found is that people who were given more information that was specific to them, that really mattered, it was down in their DNA, they were able to make better outcomes. And so this is what we're starting to see, is the more informed our healthcare consumer is, our patient, ourselves, whoever, the better we see the outcomes. And for this, I just wanted to point out, for those of you who are interested, if you're into science stuff like me, these are the genes, the genetic variations that they were looking for. And you'll see in the other chart too, the really gray, it's probably hard to see how small the type is on this. The really pale line is the group that got only the intervention, the diet information, whereas the black line is the change for people who got genetic counseling plus the diet, prescribed diet. And so this is relative change in body fat percentage. Now, this is just one thing that I got out of this because the body composition changes are very important. It makes a difference on cardiometabolic risk factors like diabetes, heart disease. But they also saw very similar types of effects with things such as total weight loss, things such as improved cardiometabolic risk factors like your blood glucose, for example, blood sugar came down, triglycerides came down, those types of things were also mirrored, which I thought was very interesting because this is a very difficult population. And I also wanted to point out, too, that one of the keys with this is that individual outcomes differed even when they followed the exact same diet. They were given this diet in a controlled environment. So they were eating the exact same thing. It's just what their body did with it was much different from person to person. I think this actually validates a lot of the feelings of people that I've worked with for several years that have tried and tried and tried and tried and tried whatever, and they don't see the same results as a friend or another person that did the same thing. So it does really individualize things and makes a difference. So the biggest question that we need to answer real quick before we end for today is how this can help us. Well, not everybody will have access, unfortunately, to genetic information at this point. In fact, we see that sometimes insurance won't reimburse it except for certain conditions. If they suspect certain things, the MTHFR actually is one thing that is reimbursed by some insurance at this point, but otherwise we still have some limitations with that. As far as getting a report of your genetics, the reports can really vary based on the company. They're usually independent labs like Nutrigenomics. It's got a X instead of the CS at the end, and other types of labs that have been approved labs. We want to make sure that they are scientifically approved and above board. You can imagine, because of the newness of this, we also have that whole periphery of con artists that have learned about this whole area, and so we want to really be careful with the lab that we use. But what we can use, even without the genetic profile, is to look at the fact that if something is not working and you're implementing things like the sodium restrictions or other things, you could look back at the science of what's being used for people that have that variant and assume that that might be you. There's no harm in trying different options or different approaches. And so that would be how we could use it even without having our own genetic information. If we have our own genetic information, though, there are some companies, again, independent labs that do this, and it could actually help us to react a little bit. They'll spell out or refer you to a dietitian. Some of them have their own dietitians who work alongside the labs. So that might be something, too, that you could do to explore that. Okay, in our path, though, with dietitians, this is actually one of the things that we find is that every path that I mentioned where dietitians practice, we really are starting to get a very good amount of evidence and good amount of different types of research that explain some of the gaps in our practice that I've seen even over the last 25 years. This is evolving very, very quickly, not only in dietetics practice, but also medical practice and pharmacogenomics. And also, we're starting to see some areas that we never really considered there to be a lot of genetic variation. We're actually seeing that they're pretty widely recognized when we start looking at genetic tests. And that small variation, again, 99% of our genetics are identical. It's just that 1% that may have a little difference from person to person. And so this really helps us with some of these other outcome areas. I mentioned, too, there are some limitations, and those limitations, insurance reimbursement, number one. It is a young science, so I'm sure we'll have the same pitfalls like we've had, even with nutrition being a relatively young science. I can remember back in the 90s where everyone was told, get away from eggs, or that science has totally changed. That science is gone, but people still follow that. So we have a lot of new information coming out, which gives the possibility that may not fully be understood. So we're looking at the evidence and where it lies. And sometimes the absence of studies doesn't mean always the absence of risks. We don't really know where the risks are. And probably the biggest issue for dietitians is that people that are not trained in programs like Manchester's, if they're in a traditional program, they're not being trained on how to interpret clinical decision-making from genetic tests. And so that's something that we need to evolve in. And they have written them into our new accreditation standards. And so I would expect other programs will catch up to ours eventually. We have them in our accreditation standards now to have exposure to nutrigenomics and also that interpretation. The other thing is ethical considerations, because you can imagine insurance companies do learn very quickly. Oh, a person's DNA, let's look and see if they're at risk of having diabetes or having kidney failure or things that cost a lot of money. And so those ethical considerations are being put into place as well. That is not something that should be either reported or judged on for predisposed conditions or other issues. It's obviously not modifiable. That's the one thing we can't change is our DNA, right? It's who we are. And so that's the ethical consideration. That's also, we have new laws coming out with what to do with the information and what is ethical use of nutrigenomic information and genetic panels. Okay, well, I'm going to stop here. I brought Buck and Polly. That's Uncle Buck is my Pyrenees, and then Polly is our black lab looking dog. They're both Pyrenees lab mixes, but they keep me busy now that my daughters have moved on to college and everything. So It's like having toddlers again. Does anyone have any questions for me? Yes.
I'm fascinated with some of the preparations that are being made for mission to Mars, that NASA's working on this habitat where people are living and trying to sort of simulate what they might experience. What is there any specific, I'm sure there's specific connections, but I'm interested in the connections between your field and preparing for something like that.
I haven't seen specific mission to Mars. I haven't seen any specific tie-ins with our field, although I'm sure there's a million of them. But specifically from my experience, I haven't seen them. However, what we are learning is that we are seeing a lot of ancient genes pop up of people who are resilient. People that have something, for example, the uncoupling protein. This is a protein in our mitochondria that makes energy. And some people are not as efficient as others with fuel. So when they eat, they burn more calories just to keep their bodies warm. And those people are a minority, and you can probably imagine why. Over time, as we've seen different populations go through cycles of hardship, they're not survivors. And so we have identified things like that, survivorship and how people adapt. We also have seen, too, that some people are superior metabolic factories. They just do much better as far as efficiency with carbohydrate, efficiency with fats of all types, not just the types that I mentioned of concern. But then also there are people that can metabolize, store, and pull from their storage easier than others. They don't have as much hormonal influence. So there's some differences there, some variation in hormonal expression and also expression at the cellular level, what's happening with what they eat. Their power factories are different. So I'm assuming that they're looking at that. Now, I also say, too, from a sports perspective, because we all know that that's so competitive, and this is a huge area right now in sports nutrition. We are seeing much more precise nutrition recommendations for different athletes. Some people are much more efficient with carbohydrate use, and they can apply that fuel like a premium gasoline, and it works so much better for them, whereas others, it will actually deteriorate their performance. And so we are looking at that, too, and how the DNA influences what gut bacteria that people have. And that also is being looked at in sports nutrition. Yeah, it's a whole new world. It's just really every time I open up any journal, I find something different.
I can't. Right now, I know what I'm thinking about, but I can't give it a label to it. The new drugs that Lilly and others are coming up with, how's that affecting or changing your approach to nutrition?
It's changing tremendously. Are you talking about semaglutides like Ozempic and Mounjaro? Are those the classes of meds? Those are all over the news right now. I'm assuming that might for diabetes and weight loss. Are those the ones that you're talking about? It is completely changing the landscape of our field. In fact, I leave Saturday for Salt Lake City for a conference, and that is the primary prime time presentation is how it really influences our field. There is a lot of good information. Actually, you hear a lot of negatives in the field, in the news. But there are some very positive things that are happening because we're seeing results actually with semaglutide in the way that it affects gut hormones and affects appetite. It's very similar to what happens after a person has bariatric surgery. And we have never come close to having that response in the past. The other thing is that this medicine has been on the shelf for a long, long time. It's just titrated in different doses and put in an injectable form. And so it's available, and it has been available for a long, long period of time, just not at the same dose. And so we are looking at that. We're also looking at how it affects things like the gut microbiome. When we look at the bacteria of the gut, we do see a shift with that medication being used. But we also see a shift with almost every type of medication. So we just don't know what it means yet. As far as nutrition is concerned, though, I know that there have been a lot of really big corporations like Weight Watchers, for example, and other corporations that have partnered with Ozempic to be able to use the drug and control the diet at the same time. And they are seeing somewhat good results up front. I haven't seen any long-term studies, but pretty much any caloric restriction will give you some good results up front. It's kind of hard to know still. But it is we do have on both sides. I have friends that are diabetes educators that can't get medications for their patients because they're so hot and heavy on the side for weight loss. So that's another big problem.
I have a question. Does 23andMe genetic testing feed into this at all?
It does. In fact, they're one of the companies that can be used for genetic testing. They have had some black eyes on their approach and on their ethics. I'm not sure that all of their reports are completely fact-based or evidence-based, but I think they've cleaned up a lot from the early years where they started doing the testing. And it does give us a lot of great information. Some of the SNPs that I mentioned earlier, those codes are actually some of the things that they're specifically looking for. There are also others too, like celiac disease and inborn errors of metabolism that are also detected through those. Yeah. And Nutrigenomics is very similar to that. There's just different labs that have been approved.
Any other question? Oh, you have an announcement. All right.
This is our last program for this school year for Friends of Manchester. And we're going to be, this summer, we have a program committee that we want to have 4 people. We had 4 people this last year, but now we're, by choice, Joyce Eberle is not going to continue. So we have a vacancy. So if you rush right up to me, as soon as we're done here, the first person, Jan Rhodes, who wasn't able to be here tonight, asked me to make this announcement. She's chairing that committee. And so we're always open to program suggestions if you have ideas, but we'll be looking in for the fall. Well, this summer we'll be meeting again. One more person to join the committee. So we'll have 4. We have 8 programs throughout the year, beginning October through May. And so that means each committee member has 2 programs to coordinate like Joanne did tonight. So it's Joanne, me, and Jan Rhodes right now. And we'll hopefully have at least one more person. Do we have anything else anybody wants to ask our guest? Thank you, Kim. Let's
Thank you for
thank her
having me.
for being here today.
Thank you.